Thank you for the invitation and thank you for the topic, which gives me once again the opportunity to talk about the new ESC heart failure guidelines. And one slide summarizing how the guidelines are currently developed at the ESC. We had meetings which were mostly virtual because of the COVID-19 pandemic. And all the recommendations had to be voted electronically by at least 75% of the task force members. And they were, of course, based on evidence. It's a large document, and I will try to summarize some peculiar aspects in this speech. First of all, the slide regarding how heart failure is diagnosed and how it is classified. We start with signs and symptoms of heart failure. Then we may have the assay of BNP or proBNP plasma levels to exclude heart failure if they are normal. And then we need an echocardiogram. And the patients are then classified based on their ejection fraction in three groups: patients with reduced ejection fraction, patients with preserved ejection fraction larger than 50%, and then the patients with mildly reduced ejection fraction with an ejection fraction between 41 and 49%. The reason of the value of this classification is that most of our positive trials in patients with heart failure were done having a low ejection fraction as an inclusion criterion. And therefore, this measurement remains mandatory for patient selection, but we will see later if there are exceptions as possible. Now, the treatment of the patients, of all the patients with heart failure and reduced ejection fraction, is based on what is now widely called as 4 pillars. That is to say, 4 groups of drugs which are recommended to all the patients because of their beneficial effects on heart failure hospitalizations and death. And in addition to ACE inhibitors or ARNI, beta blockers, and mineralocorticoid antagonists, we now have dapagliflozin or empagliflozin, that is to say SGLT2 inhibitors, which are also recommended to reduce the risk of heart failure hospitalizations and death. The reason for this new recommendation comes from 2 trials, one published in 2019, DAPA-HF, showing a benefit of dapagliflozin versus placebo on cardiovascular death and heart failure hospitalizations. And the other one, Emperor Reduced, published in 2020, showing the benefit of empagliflozin on the primary outcome of cardiovascular hospitalizations and death. The reduction in the primary composite endpoint was of 25% in both trials, with results which were consistent across these 2 trials. There are also other important findings that come from this trial. This regards the side effects, the major adverse events, that were not significantly different compared with placebo, both with dapagliflozin in DAPA-HF and with empagliflozin in Emperor Reduced. So no major harm associated with these treatments. Another important finding is that these drugs have minimal, if any, effects on systolic blood pressure, and this makes them well tolerated also in patients who have a systolic blood pressure at baseline equal or below 110 millimeters of mercury. These drugs also have a beneficial effect on the long term on kidney function. And again, these drugs have a beneficial effect which is independent from concomitant treatment, as you see here from DAPA-HF, and you see also here from EMPEROR reduced. Therefore, it is important to point out that even if these drugs were added on top versus placebo on top of standard treatment, they had a similar beneficial effect independently whether the patients were or not on the other drugs indicated to all the patients with heart failure and reduced ejection fraction. Then what else? A new indication which has been added in the current guidelines is that sacubitril/valsartan is not only indicated as a substitute to ACE inhibitors or ARBs in patients who still have a low ejection fraction, but may also be considered as a first-line treatment in patients with new onset heart failure. Although in this case, the recommendation is may be considered, is not mandatory, because the trial on which it is based is PIONEER-HF, where slightly more than 50% of the patients were not on ACE inhibitors or ARB at the start of treatment. However, this trial had a primary endpoint NT-proBNP plasma levels reduction, which was reached, but the outcome were significantly reduced with sacubitril/valsartan versus placebo. But this was only a post-hoc exploratory endpoint and not a primary endpoint because of the smaller number of patients included. What else? There are drugs which may be considered in specific conditions, and therefore we have as a new entry vericiguat, a soluble guanylate cyclase stimulator, that based on the result of the Victoria trial may be considered to improve outcome in patients who have had a recent episode of worsening heart failure. This drug was not administered to ambulatory patients with heart failure and reduced ejection fraction, and this is why the indication is more restrictive based on the enrollment criteria of Victoria. Here are the results of Victoria, a 10% significant reduction in the primary outcome, mainly driven by the reduction in heart failure hospitalizations. And again, also in this case, beneficial effects which were independent from baseline glomerular filtration rate, and which were attended by only minimal reduction in systolic blood pressure. Only in patients older than 75 years, there was a decrease in the first weeks of treatment, and then the results were not significant versus placebo. Another drug which was shown to have a beneficial effect on outcomes was omecamtiv mecarbil in the GALACTIC-HF trial published in 2020. Also in this case, there was a significant reduction in the primary outcome, mainly driven by a reduction in heart failure hospitalization, and mainly driven by a significant decrease in the patients with more severe heart failure and the reduction of ejection fraction at baseline. However, at the time of the guidelines, the drug was not accepted by the regulatory agencies, and therefore we had to use a simple language stating that currently this drug is not licensed for use in heart failure. The guidelines are done for clinical practice. However, in the future, it may be able to be considered in addition to standard therapy for HFrEF to reduce the risk of cardiovascular mortality and heart failure hospitalizations. What else? We have talked about heart failure and reduced ejection fraction to date, but our guidelines have enlarged indications also for the treatment of the patients with mildly reduced ejection fraction, that is to say 41 to 49%. The neurohormonal modulators are indicated also in these guidelines, although being the recommendation based on a post-hoc analysis of randomized controlled trials in patients with an ejection fraction above 40%, we have a 2B recommendation alone. These are the results for sacubitril/valsartan, a drug which is approved by regulatory agencies also for the patients with a below normal ejection fraction. And you see in this combined analysis that the primary outcome was reduced in the patients with an ejection fraction below 55%, more or less. Then we did not have any recommendation for patients with a preserved ejection fraction, because this was the situation at the time the guidelines were issued, which was in their final form March 2021. However, a few minutes after the guidelines were presented at the ESC meeting in September, we had the presentation of the Emperor Preserved trial, which showed the benefit of empagliflozin versus placebo on the primary outcome in the patients with an ejection fraction greater than 40%. This is a landmark trial, as it is the first one which hit the primary endpoint in the patients with preserved ejection fraction, but it could not be included in the guidelines as published after them. Then what else? We have indications for the patients with advanced heart failure. We have indications for the patients with acute heart failure. And here you have the algorithm for the diagnosis of acute heart failure. You see that there are a number of exams that can be performed at baseline, and 3 biomarkers which are indicated as for the diagnosis: BNP, NT-proBNP, and MR-proNP. They are all been shown as useful to exclude the diagnosis of acute heart failure when they are normal, and otherwise they can confirm they can show that the patient has acute heart failure, with then the need of echocardiography and a more thorough assessment. Then we had a classification of the patients with acute heart failure based on the clinical presentations. We had the exclusion of the CHAMPIT criteria, that is to say acute coronary syndrome, hypertensive crisis, mechanical lesions, pulmonary embolism, infections, and tamponade as potential causes of heart failure. And then we have the treatment which was based on the clinical presentation. Importantly, we had these new recommendations for the pre-discharge assessment of the patients hospitalized with heart failure, with the need to exclude the persistence of signs of congestion, the need to optimize medical treatment indicated by the guidelines before discharge, and then at a visit of reassessment after 1 to 2 weeks, and then the new entry of the need to assess iron deficiency and treat it with ferric carboxymaltose if there is iron deficiency, to improve symptoms and reduce rehospitalizations based on the results of AFFIRM-HF, showing the reduction in this endpoint in the patients receiving ferric carboxymaltose. Then what else? Then we had, this is depicted in the central figures, treatment which is now individualized based on the comorbidities of the patients with heart failure, with different treatments in the different clinical settings. And therefore, we have a treatment and a recommendation, namely of pulmonary vein ablation 2A, for rhythm control in the patients who have symptoms related to atrial fibrillation. And we have indications for percutaneous treatment of mitral regurgitation in the patients fulfilling the QAPT-like criteria with secondary mitral regurgitation, which is persistent despite optimal medical treatment devices, and of course with the exclusion of surgery in the patients who had other causes of who may have had other indications to surgery or are at low risk of surgery. Otherwise, class 2A indication for percutaneous treatment of mitral regurgitation. This is my last slide and regards a new comorbidity, which is now a part of our diagnostic armamentarium, above all for the patients with HFpEF, that is to say cardiac amyloidosis. We now have non-invasive tools to make a diagnosis based on immunoelectrophoresis and bone scintigraphy and SPECT. And then we have a specific treatment, at least one drug now indicated, tafamidis, for the improvement of outcome in the patients with TTR cardiac amyloidosis. This is my last slide, and I thank you for your attention.